Kim wanted me to talk about, in general, the situation and tools that are sometimes used to help legs move. Um, and I want to circle back. I think there was a point I wanted to make earlier. I know you when they, I don't recall your name, Frank. Yeah. So remember they asked, how long did it take before they diagnosed PAD for you, and you said it was right away. Correct. Immediately, right? Yeah. But I want you to take yourself back a little bit and say, did you develop a PAD at that time? So this has been growing for years, right? So you were only detected after you got to a point where you needed an urgent surgery. So what I wanted to emphasize is that you were diagnosed at the time, if you think of it. Like I think that the theme here should be detecting and diagnosing these really conditions that are life altering or life ending before they're cause a problem. So that is where this is where your primary care should be. Go to the doctor, you get seen, you get your risk factors checked, pulse examination, there's a question. You can get simple tests like an ABI, a PADnet, something to diagnose whether or not you have PAD. And then point zero here, you get diagnosed, year later, 2 years later, you get put on the right regimen, the right medications, the right, exercise and all of that stuff. And we have avoided the point. You got diagnosed that you had drop foot and you needed surgery, right? So what we want to do is we want to get people to get diagnosed earlier so that we prevent the complication related. Correct. Yes. So you don't want to diagnose PAD after you had anything, not even claudication, honestly. Because if you diagnose it early, you treat it, you remove the risk factors, and you prevent the development of symptoms. The same way with disease. So that's why we talked about the calcium score and screening. Unfortunately, we are doing a terrible job in here, in terms of finding these things before there's a problem. And that's really where it comes down to looking. And looking can be simple, you know, ABI, could be a pulse exam, could be a calcium score, really looking under the hood whether there is evidence of silent condition that is going to lead to a problem later on. So that's that. And then if you have a problem, then I think the right diagnostic test is the is where you're gonna get the right treatment. So obviously, um, there are some things that are going to be mandated. There's always going to be some medicines. You have to treat your cholesterol. You have to walk, walk, walk. You have to manage all of your risk factors. But then if you are heading towards uh, an evaluation or a procedure, there are tools to allow us, first of all, know what you have before we start a procedure. So planning is key. So if, for example, if you are looking at peripheral arterial disease, right? So there are tools to get an idea of what's going on before we go in for that angiogram, right? So we are looking at, you can get a comprehensive duplex exam, which is an ultrasound that with imaging flow. You can detect where the blockages are, how extensive they are, if there are collateral circulations, where is the problem. So you have the doctor has an idea of what they to expect.
What should you, when should you get checked?
Okay. So there are levels of things you can do to get, right? So first thing is just a general pulse examination. Like when you go to the doctor, you take your shoes off, they examine your pulses, and if you have the normal pulse exam, you can check catheter refill, you can check the feet and understand if there's any confusion. Now, uh, beyond that, you could do tests like a basic uh, ankle brachial index, which is done, in the doctor's office. Um, and then, or next level, you could do an ankle brachial index, but with PVRs and waveforms to get a little bit more extensive evaluation. The individuals to get those are individuals with risk factors at a certain age. So usually we say anybody over age 50 who has history of smoking, history of diabetes, family history of PVD, history of very high cholesterol levels, familial kind, history of heart disease, blockages or evidence of atherosclerosis anywhere, carotid, heart, anywhere else, then they should be screened. Any individual over age 70 should be screened regardless of whether they, because age is really one of the most important risk factors for having atherosclerosis. Smoking, diabetes, risk factors, family history, or existing atherosclerosis anywhere else in the body over age 50, you should get screened. All right. So the next level after we do a duplex is something called a CT angiogram, and that is a CAT scan, an angiogram done through a CT scan, not necessarily by catheter there. It's done with an IV with contrast. Are you guys familiar with a CAT scan is, CT angiogram is? That gives us even more information and exactly a roadmap of what's happening in your arterial circulation. And I use that for multiple reasons because we can really plan the procedure that way, especially in individuals who have had advanced P.A.D, right? So you want to know if, for example, if the problem is in the right leg, which way can we access safely and what is the best access point? Is it the left leg? Is it the same right leg down? Is it from the radial down? Is it from the brachial down? So it gives us an idea of how we are going to do the angiogram to begin with safely, right? So instead of going in and just guessing and poking arteries and see if everything goes well, I think we have an idea of what everything is. Number two, there are some areas that are hidden. You can't see them with an ultrasound. Inside the pelvis, ultrasound cannot see the vessels, the iliac arteries well because they're enclosed in the pelvic area. So it's very hard to see what's in there. And there are always there are areas where you could hide blockages that are cannot be detected otherwise. So people can have symptoms and they look at their legs and they say, oh, you looks like we did an ultrasound, everything looks here, but I have symptoms. So they forget to look at the source, which would be aorta and the iliac. So understanding the pulse of the aorta and the myocardium is important also for what you're going to do during the procedure. And then understanding how much calcification. So calcium makes everything very hard and rigid. So calcium is what makes bones. And if you imagine some of these vessels that you probably heard the old term hardening of the arteries. So that's what the calcium is doing to those arteries. And vessels are calcified, require certain treatment options to try to help modify that so we can expand the blockage and open the arteries, especially with that heavily calcified lesions. And then you want to know the road so you can expect and you can tell the patient ahead of time, like, and you have a multi-level occlusion where occasionally we would say, this is going to be more than 1 second. Realistically, we would open, from here to here today, let this settle down, and we're going to go to tackle the next levels. And that may be, we're going to access from below, up, or we're going to access. So instead of keeping someone in for hours and hours and hours in the procedure, risking some issues, we can stage this into procedure. And that gives us as operators time to plan, right? If you walk into an angiogram, I do I don't know what's going on in your legs. I take an angiogram, then I have to make a decision at that moment in time. How am I going to tackle this and treat it in the sequence of events, right? Imagine if I had a CT scan and I had time in my office to think about it, plan it ahead of time, and know the sequence of things and tell you what is the sequence of events should be. And I had a patient yesterday, for example, that I counseled him in the office, and I said, you know, we are going to do this to do 3 sessions because he had blockages in difficult areas that I have to fix one to get to the second to get to the third, and they have to go in a certain sequence. And but if I didn't have that information before, you know, from a CT, I would do the angiogram, I would stop, and then come back and tell them, well, it's turned out to be like that, and we have to do this and that. But I think it's better to know ahead of time. The other thing is sizing of vessels, especially in the iliac artery. I can take on the CT scan exactly what's the size of the stent that's needed, how long, diameter, and length, and if there are any other branches around it, and what kind of stents I can use, a regular stent or a covered stent. And so I am able to plan this. So I literally walk in the procedure, I say, we're going to do this, we're going to need that, we're going to need this, we're going to need that. And he walks in and there's no guesswork about what size it's going to be, and is it going to be too big or too small. Now, this is all before coming into the procedure. So I like to know right there before we walk in, we're going to access from here, left groin, we're going to go around there, we're going to do this, we're going to do that. That's kind of the plan. Now, in the procedure, then you need other devices to help you plan. Now, this is not devices to treat, these are devices to decide how to treat, okay? So the other thing we look at is using what we call endovascular ultrasound or IVUS. Plaques come in different ways. You have a soft plaque that is full of fat. You have a fibrotic plaque that is rigid, but it's not, you know, not as hard as a calcium. You have calcified plaque that is full of calcium and as rigid as a bone. And then you could clot as well. And that these are all things that are important to know because what you do for clot is different than what you do for calcium, and different than what you do for C-spine, is different than what you do for fibrotic. And sometimes if you use a device that it works really well for calcium, but the patient has clot, you are actually going to make the situation worse because you are going to spin in the clot and essentially embolize it down. And this would be hours of trying to fix clot down. So knowing what's in there is important. But if you don't know, like if you do the angiograms and you have equipoise about what size the vessel is, what kind of plaque I'm dealing with, it looks a little hazy. Is there a clot? There's no clot. Is there a dissection? I don't know. Do you guys familiar what a term dissection is? Section is basically the 3 layers of the artery. 3 layers. The inner layer is kind of split, and it splits from the wall of the artery. So you have like a little flap inside the artery. So is there a dissection? Some people can have a spontaneous dissection next to plaque. So understanding all of is important because then there are certain devices that you can't use. If there's a section, it would better use certain other different devices. So if there's a question on the angiogram, on the morphology of the plaque, the size of the vessel, the presence of clot, the presence of dissection, then use the tools to find out what exactly is going on so you can tailor the treatment in a way. Go ahead. Yes. So yes, so CT angiogram can detect clot. Um, uh, depends on the age of the clot. So initially, the clot, when it's fresh, it has a different texture and color to it, really dark. But when the clot has been there for a while and it's embedded, it becomes more like the same texture and color scheme as the vessel wall. So you may be able, you may not be able to detect the differences, but fresh clot you should be able to detect on a CT angiogram. And those obviously you're going to treat them differently because clot you have to manage. Your goal is to get that out and not send it down. So that's the really key. And there are devices to do that to reuse it. It depends on the amount of clot and what you expect you can achieve. Sometimes we drip, we really put a catheter in and drip PPA in there for a few hours and come back and read. And sometimes we can do something to get it out right away. So it depends on how much and what's the risk of something going. Or iliac. Okay. Yeah. So the best thing is not to have any food.
So he's asking, is it better to have soft plaque or hard plaque? And you're saying
The best thing is zero.
zero plaque.
Each one brings its own challenges. So the issue with very hard plaque in the iliac is hard plaque is uh like you can imagine you have a rock. Like sometimes it's actually just shaped like a rock on the vessel wall. Now, uh, unfortunately, this still happens, but thankfully, I mean, we have designed it in a way, the way we evaluate and treat that. I'm gonna knock on wood that I haven't seen this in a very long time. Is that something called an iliac perforation? So you go in, you open it, the vessel with a balloon. You have on the wall something like this. Yeah, now you're pushing it with a balloon, and it just tears through the wall. Iliac perforation can be because you have open bleeding inside the pelvis, and the pelvis can take a lot of blood. So that's one thing. So the reason why we don't see this now is that we plan. So uh, we do CT. I can tell you on the CT how much calcium it is, what's the size of the iliac artery, and the location. So I can tell, I look at it and say, okay, this is a chunk of calcium that could be a problem. So, and this is the size of the vessel. So the keys to preventing perforation is you have to manage the calcium, and you have to make sure you're not super oversized on the balloon stents, and you have to put a cover stent. So we go in with that plan. So we go in, we use something called a shock wave. So that's a special kind of balloon that uses shock wave. So imagine people that have kidney stones and they do the shockwave therapy, the lithotripsy. So they put them in water, they shock, and it breaks the the stone. So you take one rock and you can smash it with a shockwave and you break it into 10 pieces. So when you break a rock into 10 pieces, then you can smush them together easier. If you break a rock into 20 pieces, you can smush them you can smush them easy. They will not go down because all of that is inside the vessel wall. So it's covered on all each side. So people say, oh, is it not going to shower down? No, it's not going to shower down. If the rock is broken apart inside the vessel wall, so nothing is in the bloodstream. So usually we come in, we have the right side shock wave, we use the shocks to soften the calcium, and then we go in with a balloon very gently and slowly and deliberately and monitoring blood pressure, monitoring patients for symptoms, and then we come in and my practice has been to put for those cover stents. Cover stents in the iliacs work really well. They have very low, a very high patency rate, very low. You cannot grow plaque in cover stent. That's number one. Number two is they make the procedure much safer because there's no way you're not gonna bleed because it's covered, so it's creating a seal. There's no perforation. So using those steps, I would say I've not seen an iliac perforation. So that's the now soft plaque. You have to be careful. Is it soft? Is there any clot in it or no? Some of it can be cheesy craters, cheesy kind of plaque. You put a stent in it, it can kind of through the stent struts. So there's certain situation where sometimes I put a cover stent, but I just want to make sure I don't get it squared into a brain. So sometimes you have to protect the branches. And so you have to just, each one has a little bit of different um, strategies. So you just want to make sure that you use the right strategy for the right